So thank you all for your patience and attendance.
Thank you, Doctor. Good afternoon, all. So we'll just give another 2 minutes before we proceed to commence with the webinar. I hope I can be heard.
Yes.
Yes, Dr. Afan.
So I think we may proceed now. Good evening, colleagues, professors, senior colleagues, and my colleagues, distinguished speakers and participants. To welcome you all to today's webinar. And the topic is the topic is the complications of snake bites and the role of the anesthetist and ICU involvement. So I want to confirm that everybody can hear me. and can follow the chat when I introduce the moderator and the speakers today. Can everybody hear me, please?
Yes.
Yes, sir.
Okay. Thank you very much for that. Thank you. We'll have to keep our microphones muted during the course of the presentation, and I'll advise us to use the chat box for any questions we have during the period of the presentation until the Q&A session. Permit me to introduce our moderator for today, who would take over from me after this brief introduction. Yes, sorry, let me just get. Hello, Dr. Afan, please. My network is a bit shaky.
Okay. Hello, sir.
Am I still on the?
Yes, can you hear me, sir?
Okay,
We can
please.
still hear you. Okay.
Okay, I lost my Zoom. Okay, so I'll be introducing today's moderator as Dr. Abubakar Bala. He's a lecturer, stroke consultant, anesthetist at the Abubakar Tafawa Balewa University Teaching Hospital, Bauchi, in Bauchi State. I don't know if he's present. He'll be taking over the moderation from here on to introduce the speaker. Thank you. Dr. Abubakar, Dr. Bala, please.
Yeah, thank you very much, Dr. Odukoye. Thank you for
Thank you, sir.
brief introduction. I am Dr. Abubakar Balla, Senior Lecturer, Department of Anesthesia and Critical Care, Abubakar Tafawa Balewa University Teaching Hospital, and I will be the moderator today. Good evening, everyone, and I welcome you to our fourth session of the 10th webinar series organized by the Nigerian Society of Anesthesia, the Education Committee. I also want to acknowledge the presence of everyone that has spared time to join the webinar, especially our teachers, trainers, mentors. Thank you for sparing time to join. Today, we are going to have a presentation by Dr. Afiong Victoria Elumelu. Dr. Elumelu is a consultant anesthetist and critical care specialist with the Department of Anesthesia and Critical Care, National Hospital Abuja, and also Damat General Hospital in the Kingdom of Saudi Arabia. Today, she will be talking about the complications of snake bite. And before I give her the space to start presenting, I just want to recap our ground rules. Please, those of us whose phones don't bear our name, like the Xiaomi or something, try to rename your devices, and we should mute our mics until you are called upon. You indicate that by raising your hand. If you have any question, comment, contribution, or any concern, you can drop it on the chat box. Then later, if you are required to speak, we'll identify you to speak. But if it is to read the question or the comment, we'll read it and the presenter will answer. Or if you direct your question to anyone, we'll call on the person to attend to your question. The presentation is going to last about 35 minutes. And on this note, I welcome Dr. Afiong Elumelu to share her slide and start the presentation. Thank you very much.
Thank you, Dr. Bala. Thank you very much. Let me start slideshow. From beginning. Okay. Good afternoon, my esteemed colleagues, senior colleagues, teachers, mentors. I'm presenting complications of snake bites, the role of the anesthetist and ICU involvement. For some reason, my camera is not showing my face, but I will still go ahead. This is the outline I'm using in introduction, epidemiology and spread of snakes, classification and the venom of snakes. I will still, even though this lecture is for anesthetists and ICU, but I'll still have to run through basic first aid and transportation, clinical management, ICU role, prevention challenges. So snake bites. Going forward, snake bite is a pertinent global public health problem. Bites and venom sprays can lead to death, illness, blindness, and permanent disability. The World Health Organization globally estimates about up to 5.4 million snake bites annually, with a lot of illnesses and as much as 158,000 annual deaths globally, but significant underreporting occurs. So most snakebite morbidity and mortalities occur in the tropical and subtropical regions. Agricultural workers, cattle herders, farmers, palm wine tappers in the forested areas, swamp walkers, children, and rural dwellers are most affected. Now, in these areas, tropical and subtropical regions, have countries and regions that have challenges with access and affordability of healthcare, as well as certain cultural practices and preferences that impact on their management of snake bites. So WHO has officially classified snake bite as a high priority neglected tropical disease, and anti-snake venom is listed on the essential drugs list. This slide shows estimated annual snake bite deaths per year. India tops the list globally, followed by Bangladesh. Nigeria is a hard third, but these are estimates of 4,000 to 5,000 deaths per year. As I said, there is significant underreporting. So we go back to general classification of snakes. These are reptiles of the order Serpentes. There are so many distinct, over about 39,000 distinct snake species, and snakes are found everywhere in the world, except for Antarctica, which is all snow and ice and has no small animals that snakes would feed on. And these creatures, snakes, have adapted themselves to all type of environments: desert, savanna, highlands, tropical regions, rocky mountains, water, on top of trees, everywhere. It's estimated that of all these numerous snakes, 80% are non-venomous. And of the rest, about 12% are capable of causing serious problems in people. I'm not a zoologist, but generally as classification, you can broadly classify snakes into two broad classifications according to their hunting method. Those that kill by suffocation, including the boas and pythons, they bite, hold on, suffocate, kill the prey, and eat. And then those that bite and inject poison into their prey. Of the venomous snakes, there are some broad categories. You have the elapids, genus Elapidae. These are the long, slim, fast-moving snakes. They have short, fixed fangs in the front of the mouth, and they mainly have neurotoxic venom. But you'll find that venom can, according to this group, some are cytotoxic, some hemotoxic, but mainly neurotoxic. So these elapids include snakes like the cobras, the mambas, sea snakes, and coral snakes. You have genus Viperidae. These are shorter and heavier snakes. They have long hinged, movable fangs. Those fangs can retract. When they want to bite, the fangs come forward and bite and inject venom. They generally have hemotoxic or cytotoxic venom. These include the saw-scaled or carpet vipers, rattlesnakes in the America, copperheads in the America, and adders, including puff adders, which are very deadly here in Nigeria. And then you have the Colubridae, genus Colubridae. These snakes are a very diverse group of snakes. They have a very large number of varieties of snakes in Colubridae. They tend to have rear-based fangs at the back of the mouth. These include boomslangs, which are usually more in southern Africa, but are also found in Nigeria. and rat snakes and king snakes. You have the burrowing snakes. They tend to hide in holes. Genus Attracta spididae or something like that. Usually smaller. These ones have sideways protruding snakes. They strike and pull back, and it scratches you and gives the venom. Then you have water snakes, freshwater, and sea snakes. And of course, remember I said 80% of snakes are non-venomous. And this is a little bit of comparison of the snake fangs. On top is elapid with the short, fixed fangs in front. In the middle is vipers, which is Viperidae. They have longer fangs, which are retracted, but when they want to bite, they bring out and then inject the venom. And at the bottom, you have this Colubridae with the rear-facing venomous fangs. And this is the worldwide distribution of snakes, venomous snakes. You can see that almost quite frankly, every country and continent in the planet has snakes. So in Nigeria, the incidence of snake bites is often underreported. WHO estimates for the year 2007, based on a study by NACIDI, estimated about 174 snake bites per 100,000 population per year. Considering we have a 200 million population, you can imagine how many snake bites we have in Nigeria per year. And this number is much less than an earlier 1974 study in an area in the Benue Valley by an earlier scholar who estimated 497 bites per 100,000 population. You can imagine the number if we extrapolate with our current day population. Reportedly, speaking to a herpetologist, we have about 9 types of cobra in Nigeria, 7 types of vipers, we have boomslang. But of all these snakes, the saw-scaled or the carpet viper, Echis ocellatus, is reported to be responsible for 90% of bites in Nigeria and 60% of deaths. We'll still come back to that. So in Nigeria, we have cobras, we have spitting cobras, Naja catiensis, Naja nigricollis, cytotoxic venom straight to the eye. We have neurotoxic venoms, Naja haje, Naja nigricollis again, and Naja mosambicus and others. These bite and give neurotoxic venom. Then we have the mambas, the Jameson's green mamba. It's a green snake, stays on the trees. You have the fast and aggressive black mamba. Remember I talked about burrowing snakes that stay in their holes, stiletto snakes. Then of course we have the vipers. Remember I said they are short, thick sets. And Echis ocellatus, or the West African carpet viper, is said to be this Gobe danisa or Echieteka, which literally translated, tomorrow is too far, you might die before tomorrow. And of course we also have adders, the puff adder, very venomous and deadly, Bitis arietans. So let's move forward. That's a black cobra on the left, and that's the West African banded cobra on the right, this picture. The West African carpet viper, Echis ocellatus, Gobe danisa. These are pictures of 2. They have this marking on their back, like eyes. These white marks at intervals down the dorsum, and that's where they get the name ocellatus. It shows like eyes. And that's a way to identify them if you are brave enough to go close to them. You have the mambas, is the black mamba. It's not really called black mamba because the skin is black, but when it opens the mouth, the mucous membranes show black. And this is our herpetologist, Professor Edem Enyang. He sent me a picture of this green mamba. It's a tree snake found in the southern part of Nigeria. This is the Gabon viper. It's huge. You have a picture, you see that picture with the prof herpetologist, you see how big it is. It's actually a gentle and slow moving snake, but it's capable of delivering a really very fast bite. It has the hinged fangs and can deliver it. It has the world record of delivering the highest amount of venom of snakes in the world. That is the information I got from the herpetologist. How do you identify a venomous or a non-venomous snake? Non-venomous snakes have triangle-shaped heads. They tend to have elliptical pupils. You see the fangs, and they tend to have a groove between the eyes or between the nose. Non-venomous snakes have a rounded head, round pupil. They don't have fangs showing. They don't have an elliptical pupil. But it is not completely like this. There's some venomous snakes that have round pupils. This is just a general guide. So Snakes will bite to immobilize their prey so they can eat. Frogs, rats, lizards, things like that. But they also bite as a defensive strategy when they feel threatened. And the snake venoms are a complex mix of both toxic and non-toxic components. It's considered to be 90% protein by dry weight, and it consists of enzymes, polypeptides, and in some cases, heavy metals. Of all the snake bites, it's estimated that 50%, half of snake bites, are dry bites, in which the snake has bitten you, but no venom is released. The potency of the venom of a snake, the effects of envenomation, these depend on the species of the snake. Some are more potent than others. The size, if your skin is penetrated by one or two fangs, if you have multiple bites. Some snakes are capable of biting, rearing, and going back up to 3, 4 times before you can blink your eye. They've struck multiple times, and each time injecting venom. And of course, the age of the snake. Okay. These venoms cause local tissue damage at the bite site and are spread both through the blood and the lymphatics. They contain a lot of things, including procoagulant and anticoagulant enzymes, cytolytic or necrotoxic toxins. You have hemolytic toxins, myolytic phospholipase A2. This phospholipase A2 has been very well studied, as I'm informed. They contain neurotoxins, pre- and postsynaptic neurotoxins. They destroy your nerve endings. They interfere with the release of acetylcholine. Postsynaptically, they compete at the neuromuscular junction with acetylcholine, cause fasciculation, and cause flaccid paralysis. They contain hemorrhagins, cardiodepressive toxins, and a complex mix of effects by snake venom according to the type of snake. So you have what we call cytotoxic envenomation. This causes largely tissue damage. There's pain, there's tissue swelling, there's blood-stained tissue leakage from the bite wound. Patient might go into hypovolemic shock. There's blistering, bruising, necrosis leading on to gangrene, and you can proceed on to acute renal failure due to the effects of rhabdomyolysis and myoglobinuria. There could be scarring after treatment, and you could have permanent disability if you recover from cytotoxic envenomation. You have hemotoxic envenomation. This really disrupts clotting and clotting process. You could have a consumptive coagulopathy. There are procoagulant venoms, which will consume your clotting proteins in the body, and then you're not able to control coagulation. And then you also have anticoagulant components in the venom. So you have bleeding from the bite wound. From all wounds that have healed, you suddenly see them starting to bleed. Bleeding from the gums, it has hematuria, GI bleed, intracranial bleeding, which could kill, retroperitoneal bleeding. In pregnant women, you could have uterine bleeding, antepartum or postpartum hemorrhage, and could lead to death. In neurotoxic envenomation, this affects the brains and the nervous tissues. There's a disruption of neuromuscular function, as I explained. You could have paresthesia of the tongue and lips, abnormalities of taste and smell. There's heaviness of the eyelids, there's ptosis, diplopia, and ophthalmoplegia. There is a descending weakness and muscle paralysis. Patient could have profuse salivation, profuse and stringy saliva. Conversely, the patient could have a dry mouth. There's nausea and vomiting, difficulty with speech. We have sometimes what is called the hangman's sign. The person cannot keep the head up. The head is bent down like somebody whose neck is broken by the hangman. And that's because there's paralysis of the flexors of the neck, the long muscles that keep the head up. These are paralyzed, and the person cannot keep up his head. There's respiratory failure, which proceeds on to death if intervention is not taken. What are the features of the snake bites? There's pain. They might see fang marks, but you might not see them. There's local bleeding, swelling of the area, swelling of the limb, sometimes even swelling of the entire body. It could be massive in as short as 10 to 20 minutes. Regional lymph nodes may swell and be tender. There's formation of blisters, sometimes blood-filled blisters. They could have pigmentation because these enzymes in the snake toxin could be affecting your melanin. Could have pigmentation, depigmentation. Depending on the time of presentation, you could have smell of putrefaction with necrosis and sloughing of the tissue. How do you identify a venomous snake bite? You might see the two fang marks. And if you see a row of marks without venom, you might have you might identify that it's a non-venomous snake. What are the differential diagnoses of snake bites? Arthropod bites scorpions, centipedes, spiders, skin puncture by thorns or twigs. If you're bitten in the water, it could be that fish scale or fish bite, or the back spine of a fish might prick you and you think it's a water snake. Basic first aid: safely remove the victim from the area. Remove the snake from the snake bite if it's still attached, and try to still calm yourself and calm the panicked victim. Immediately try to remove constricting clothes, rings, and bangles from the bitten limb because we're expecting swelling. Use a splint or a sling to immobilize the bitten limb and to keep it at a level below the heart. Preferably immobilize the whole patient because movement and muscular contractions promote the spread of venom. If you have a spritzing of venom into the eyes, immediately wash the eyes thoroughly with water or milk or a bland liquid. Transport the patient to the nearest healthcare facility. I'll get on to do's and don'ts. You see on the right here, you apply a firm bandage, pressure bandage, and use a stick to immobilize the limb before transportation. This helps to reduce excess movement of the limb and muscle contractions that will promote the spread of venom. Tourniquets are not allowed. Things not to do. Do not allow the victim to run in panic or to run about while seeking help. Do not apply tight arterial tourniquets. These will contribute to gangrene because there's no blood flow to the limb. This will contribute to concentration of local venom in the area bitten. And sometimes when you finally get to help and you loosen the tight arterial tourniquet, there's risk of hypotension, venom is released. You can have clotting in that tied limb, tied below the tourniquet, and when you release it, you might have embolism. Try not to do cauterizing or burning or making incisions on the snake bite area. Don't tattoo. Don't try to do prophylactic amputation of the affected digit. Do not try to suck out the venom. And do not unduly waste time trying to catch and still kill the snake while delaying transfer to the hospital. Remember, proximity to kill the snake is the same proximity for the snake to bite you. So you should be careful with that. And Blaylock is a herpetologist from South Africa. He gave some clinical syndromes of snake bites, which guide your decision of how to treat. Syndrome 1, marked swelling with blood that coagulates. Syndrome 2, marked local swelling with blood that doesn't coagulate. You know it's hemotoxic. Syndrome 3, progressive paralysis and weakness. You know that's neurotoxic snake. Syndrome 4, mild swelling alone, likely not to be venomous. Syndrome 5, mild or negligible swelling, but the blood doesn't coagulate. You know it's hemotoxic. Syndrome 6, moderate to marked local swelling with neurotoxicity. That could be a mix of cytotoxic and neurotoxic. This is a scheme developed in South Africa and adapted for syndromic management of snake bites in Africa and other ways. So, once again, you get to the healthcare center, you reassure the patients, you have to examine the bite sites, check the regional lymph nodes, the gums, try to ask the patient to open his eyes. You check for eye movements. If there's paralysis, you know you're dealing with a neurotoxic snake. You have to conduct a full clinical examination. Vital signs are taken and recorded: heart rate, blood pressure, respiratory rates, SpO2. You encourage the patient to urinate upon arrival to check if there's blood in the urine. And that will also let, if the urine is clear, at intervals, if you notice blood in the urine, it gives you an idea that it's a hemotoxic venom. What's the history of the bite? The site of the bite? Where were you located? What time? What activity were you doing that led to the bite? You know that this black cobra can even bite a sleeping person, this Naja nigricollis. Time duration since the bite, and if any intervention was taken out before coming to hospital. You must get IV access and start fluids, IV access for fluids, for administration of antivenom, for analgesia, and for emergency medication as indicated. Now you take blood for bedside whole blood clotting time. For this, use a new, dry, clean glass container, not washed with water. It will give you a wrong indication, and not a plastic container. You take some blood, put in this glass bottle, and put by the bedside of the patient or where you can access. If after 20 minutes you tilt the bottle, and the blood is not clotted, you have a very good idea that you're dealing with a hemotoxic venom. And this is a very good and valuable bedside test for snake bites. So it gives a very good indication of coagulation. Non-clotting blood after 20 minutes is good. Other investigations, blood is taken for other investigations while the glass container is sitting and waiting for the blood clotting time. You do your blood counts, full blood counts, your clotting profile, you do renal function test,
So
creatine
at that
kinase.
point, you're going to be paid. If the patient says, no, leave me alone, you cannot force the patient. You cannot
Analgesia.
force the patient. The patient has
Oral,
not cooperating.
please, can we mute?
And yes, if you ask, they went to
Analgesia.
the
Oral paracetamol is preferable. You try to avoid aspirin or non-steroidal anti-inflammatory drugs because these can enhance bleeding. You can give opioids cautiously, bearing in mind that opioids can depress respiration, and this is a patient you're trying to check for neurotoxic symptoms. Observe the patient for 24 hours in hospital, preferably in the ICU or HDU if feasible. You have to do continuous multi-parameter monitoring, hourly checks for the level of consciousness, checking for ptosis, vital signs, local swelling, is there urine, how is the urine output, and for any new signs. Local limb swelling may be massive with compartment syndrome, which will lead to nerve entrapment, vessel entrapment, so surgical intervention may be required. Now, going back to this checking for ptosis, in neurotoxicity, the frontalis muscle contracts when you ask the patient to look up, but the eyelids don't lift up, and ptosis is evident. These are two pictures of patients with ptosis. The picture on the right, you see the wrinkling of the forehead, frontalis is contracting well, but the eyelids cannot open. Clinical management also goes on with tetanus prophylaxis. You may or may not need to give empirical antibiotics. If the patient develops severe bleeding or anemia, you have to consider transfusion of blood and blood products, whole blood, fresh frozen plasma, cryoprecipitate or platelet transfusion as indicated, because yes, there could be thrombocytopenia as a result of snake bites. If the patient is in shock, you give IV fluids, you give crystalloids. If you have difficulty with IV access, consider femoral access, especially for children, or intraosseous cannulation, and you may need to do a central line insertion for venous access. If the patient is vomiting, turn the patient on the side, give IV promethazine, chlorpromazine, or ondansetron to stop the vomiting. What is the role of neostigmine? Remember, we said that snake venom will compete with acetylcholine at the motor end plates. So neostigmine helps to improve muscle strength by raising the increasing the amount of acetylcholine at the motor end plates and competitively displacing snake venom from the postsynaptic acetylcholine receptors. If you're giving neostigmine, be careful to give atropine as well. The patient might be in a critical state, maybe moribund. You use the ABC approach: airway, breathing, and circulation. If there's respiratory distress or failure, please open the airway, give oxygen, place in left lateral position, put an oropharyngeal airway, and consider early intubation. If the patient is unresponsive, CPR will need to be carried out immediately. Patient might present late with extensive necrosis, gangrene. Of course, there will be surgical debridement, and as an anesthetist, you might be required to assist with local or general anesthesia. We have to beware of hyperkalemia if there's marked breakdown of tissue and muscle. This hyperkalemia can predispose to cardiac arrest. And you also look out for signs of renal failure. We have to consider peritoneal dialysis or hemodialysis. Snake antivenom. This is the only effective antidote against snake venom. It's produced from the hyperimmune serum of horses and other large domestic mammals. It could be monovalent against a single snake species, like they have against boomslang snakes in South Africa, or it might be polyvalent against a number of snake species. They use pooled venom to get the hyperimmune serum against different snake species. It may be presented as a dry powder, which you reconstitute just before use, or it may be a liquid that needs to be kept in a fridge. It is scarce, it is expensive, and it has severe side effects. Right now, we don't manufacture any in Nigeria. So indication for antivenom treatment after bites by African snakes, WHO guidelines. If you have neurotoxicity, if you have spontaneous systemic bleeding, incoagulable blood after the 20-minute whole blood clotting time, any cardiovascular abnormality, hypotension, shock, arrhythmias, ECG changes, and if you have local features like extensive swelling, more than half of the beaten limb, rapidly progressive swelling, or if you have bites on fingers and toes. This again is a snake bite of a finger of a patient. Properly administered antivenom can reverse coagulopathy, can prevent further tissue breakdown, and can reverse the neurotoxic effects, though this might be slower. If you give antivenom, your supportive medical and ICU treatment still needs to be continued. And here we come to Echitab, snake antivenom. It's produced in Costa Rica. This vial comes as a 10 ml vial, which neutralizes not less than 30 milligram venom of Echis ocellatus, 10 milligram venom of Bitis arietans, puff adder, and 2 milligram of N. Naja nigricollis. This specifically works against these 3 snakes and other snakes. It comes as a 10 ml bottle. It's stored in the fridge at 2 to 8 degrees centigrade, and it has a 3-year shelf life in the fridge. So Echitab is a polyvalent snake antivenom made up by the pooled venom of the more common venomous snakes across Africa. It comes in 10 ml vials, and your dosage is 4 vials at once. So you dilute the 40 ml of the 4 vials in 500 ml of normal saline and give over 1 hour. You start to give slowly to look out for any hypersensitivity reaction. And if there's no reaction, you complete the 500 ml in 1 hour. For children, you give the same 4 vials, 40 ml, but you're going to give in less dilution fluid. So you're going to give children in 200 ml of normal saline, not 500 ml like adults. Children must receive the same dosage of anti-snake venom as adults because they receive the same volume of venom per snake bite. It's only the volume of dilution that will reduce for children. Before you give Echitab, you have to ask for history of atopy. Does the patient have asthma? Has the patient ever suffered a reaction to any immunoglobulin medication like antitetanus serum? Or you can try a skin test with subdermal Echitab, diluted 1 to 100, 0.1 ml. You must always have, before you give Echitab or any anti-snake venom, you have your antihistamine ready, corticosteroids ready, and adrenaline, 1 in 1,000, 1 ampoule. Pre-treatment may be indicated if there is a history of atopy. And then you have to observe the patient. After giving this anti-snake venom, you observe the patient in the ICU for 12 hours. If the symptoms are not reversed, or the patient gets better, but symptoms reoccur due to late absorption from the bite site, you repeat another dose of 4 vials in 500 ml of normal saline and 200 ml for children. Studies have been done. Echitab is effective against not just these 3 snake species I mentioned, but against several African snakes, Bitis arietans, Gabonica, rhinoceros, all these. So it's effective for West African snake bites as well as Central and East African snake bites and going down to Southern Africa. Now, I must mention that we must be aware of importing or using Indian-made antivenom. These Indian produced antivenoms are effective against Indian or Asian snake venom, not African snake venoms. So you might use them and the patient still dies. So what are the reactions to anti-snake venom? You could have immediate reactions, hypersensitivity reactions, urticaria, hypotension, bronchospasm. If you notice that, you stop the infusion of antivenom, administer IV antihistamines and corticosteroids. If the reaction is very severe, you have to give subcutaneous adrenaline, 1 in 1,000. And once the manifestations of the adverse reaction are controlled, you have to restart the infusion because the anti-snake venom is the only thing that will save the patient's life. You can have late adverse reactions like serum sickness, which can occur within 5 to 20 days after administration in a small percentage of patients. And these are treated with antihistamines and corticosteroids. Remember, there is no contraindication to snake antivenom. The alternative is worse, so we have to forge ahead. What is the role of the anesthetist or the intensivist? We might be called upon to aid you might be called upon for first aid to assist with resuscitation. We're called upon for airway control and ventilatory support. We are going to be in charge of the patient in ICU, continuous monitoring, ventilatory support, inotropic support, management of hypersensitivity reactions, continuous investigations. We might be called upon immediately for correction of compartment syndrome or for debridement of necrotic tissue. We might be called upon much later for corrective surgeries or amputation. And of course, we'll be called upon for CPR as an anesthetist or intensivist. Hopefully, we will not be a victim of snake bites. And that's why I've run through first aid and resuscitation, because anything can happen. Snakes can spit venom into the eye. They cause corneal ulceration. Early treatment gives the best results. Flush liberally with water. You get to the hospital, they give drop of local anesthetic, they give mydriatic, topical antibiotics, and pad. For snake venom ophthalmia, anti-snake venom, systemic or local, is not indicated. But if it's not treated, it can result in permanent blindness. This is a picture of late-stage deformity from a cobra bite. Remember, I said cobras are cytotoxic. Prevention of snake bites. Carry out periodic fumigation of homes, workspace, business locations, places of assembly. No rats means less snakes. Be careful with poisons. Some of us might want to buy certain poison to kill the rats. Be careful, especially if you have small children at home. Careful with storage of poison. Be careful with administration of poison to yourself and others. Trim your lawns. Clear off bushy areas, keep your surroundings clean. Beware of piles of firewood or discarded building materials around the home. They make good hiding place for rats and hiding place for snakes. Entry points into the house, you have to seal them. Cracks or gaps in the walls, windows, toilets, and doors. Try not to have tree branches overhanging and touching the roof of your home or your office. Also, raise beds above the floor level. Try not to sleep on mats or mattresses on the floor, because some snakes will slither and bite at night. Use insecticide-treated nets. They deter mosquitoes, but they also deter snakes as well. That's an interesting thing. Insecticide-treated nets will prevent snakes that bite you during sleeping. Be careful when you're doing your side hustle, breeding chickens and eggs. These attract snakes and could result in snake bites. Pets help. Cats and dogs can deter snakes. This snake was killed in my own compound, in my house in Abuja. My dogs were barking so much at night and came out in the morning and saw the dead snake. I have no idea whether it's viper or elapid or whatever. A snake is a snake. So this happened in October. And we also still saw another snake because my neighbor is building. So we all have to be careful. We won't just sit and say we're anesthetists, we don't do first aid of snake bites. It can happen, it could be closer than you think. Prevention: at night, watch your step. Use a torch to illuminate your paths. Wear sturdy shoes when walking at night. Use a stick, to clear the way if you're going in the bush at night. Never put your hand down holes if you're trying to catch rats or things. People do that in the rural areas. Beware of dead or apparently dead snakes. Snake venom can still be delivered from the scratch of the fangs of a dead snake. And then some species of snake can pretend to be dead. You go closer, they rear and bite you. So even when snakes are dead, you have to carry out all precautions. What are the challenges with treatment of snake bites in Nigeria and in Africa? As I said, most people are poor and most people are in the rural areas that don't have hospitals. There's difficulty in accessing healthcare, transportation. So you find maybe delayed or neglected cases. And this is also a reason why people believe more in the traditional snake bite remedies, which in this lecture I have no authority or knowledge of traditional snake bite remedies, so I cannot say if they're good or bad, but I've mentioned the bad things we shouldn't do. So there's difficulty in accessing healthcare. For those who come to the hospital, there's poor healthcare financing, lack of funds. People come and they might not have the funds to be able to afford the anti-snake venom and all the things we're doing, ICU admission. We do not have regular ambulance services in Nigeria, so this doesn't help the snake bite victim. We have limited access to and inadequate supplies of snake antivenom. We have limited or no production of antivenom in Nigeria. Echita, which is a wonderful thing, is produced in Costa Rica, and ECHITAB is actually a collaboration between Nigeria and the Costa Rica University of Costa Rica, and they produce that. But it's still produced there in Costa Rica, not in Nigeria, to the best of my knowledge. Even when you see the antivenom, the cost is high. And then there's also this limited collaboration and communication between hospitals, agencies, and healthcare institutions on the availability of antivenom. So we need to talk more to ourselves and build bridges and communication so we can say, oh, somebody was bitten in Guagualada, you can call a particular snake bites hotline and they can direct or send the antivenom to the person from, let's say, Central Abuja to Guagualada, and we have that replicated in other states. So we need to have collaborations to help. So in conclusion, the anesthetist or the ICU physician has an important role to play in the management of snake bites, from immediate resuscitative management to continued ICU care, and then to giving anesthesia for surgical intervention. The anesthetist may be called upon to assist. So it's imperative that anesthetists know the effects, the course of snake bites pathology, and the management of snake bite as well as its complications. So this is a symbol of the World Health Organization. You see the snake on the pole. I'm sure some of us know the origin of that symbol. And I thank you for listening, and I'll be happy to take some questions. You can recognize your specialty of medicine from this cartoon that I pulled down from the internet. Anesthesia shows the sleepy snake with the tongue sticking out. So thank you very much. These are some of my references, and I will give the floor back to the moderator. I can stop sharing now.
Yes, thank you very much, Dr. Elumelu, for this excellent presentation. We all agree that this is a timely presentation and it's presented on time and within the allocated time. So I checked through the comment section. I've not seen any question, but we'll allow the participants, anyone that has question can indicate by raising up the hand or write in the comment box. Okay, there is something in the comment box.
Okay.
Okay, this is a comment by Dr. Adesion Aderonke. Excellent, Dr. Elumelu. Precious also saying thank you, ma. Presentation was very good. So question, comments, contributions.
Wow. Okay. If we have no questions, I first of all apologize. There's something wrong with the video of my device. So that's just my still picture up there. I apologize.
There is a question here from Dr. Martins Odum.
Okay.
He said, is there a time frame between arrival of the victim to the hospital and administration of the antivenom?
Okay.
Let me read another question. Maybe you answer them. From Precious, please, for patients who present with tied limb, how do we manage them? Those who present with tied limbs.
Okay. Can I take them as they come? Because I'll probably forget the first question. If someone says Bluestone, I don't know. I've heard about it. I have no idea how it works.
Okay.
Time frame between the arrival of the victim to the hospital. It should be as soon as possible. Despite this wonderful presentation, there are some snakes that are their venom is so potent that the person could collapse and could die within 1 or 2 hours. There are rare cases like that. But then, what I would say is as soon as possible. As soon as possible. As soon as possible.
Okay,
even when some people come, go ahead, please.
Yeah, before we go to the other questions, we have Professor Nwaso is raising up her hand. I think, Prof, you can unmute.
Maybe, okay.
Thank you very much. Thanks for this presentation. Thank you, Dr. Bala, for recognition. Thank you, Dr. Elumelu, for this very excellent presentation. It's really timely, like Dr. Bala said. I just want to say that management of snake bites is very important and it's very relevant. Because of this, WFSA has an update in anesthesia that is dedicated to the management of snake bites. So we can do well to check in the WFSA resources, and we will see it there. It can also help us, give us some more information in addition to what Dr. Elumelu has told us. I want to say that in addition to all the things that she has said, that it's important to know that sometimes when you're called to do the management of pain, that one of the roles of the anesthetist in this pain management is to give intravenous, is to give regional block. Is to give regional block for either if they want to do the Bremor, or if there has been a local swelling and all that, and that area is really very painful, the anesthetist be called upon to actually do that. But that if it is a snake that is affecting the that is affecting the clotting profile, this can be quite, challenging, in the sense that by the time you want to do your block and you are putting your needles, you may experience a lot of bleeding, much more than you can cope with. So this care has to be taken in doing this, or in giving this regional block as a way of pain relief. And we should also note that all the things that Dr. Elumelu said are very, very valid. But even while you are doing a lot of them, there are so many drug interactions that can happen. There are so many things that can go wrong. Giving the anti-snake venom can also trigger its own anaphylaxis and other problems. And then also giving neostigmine. Some people, while they say that it can be used to control the excessive salivation and all those effects of the because of the effect of the snake venom, this neostigmine can also interact with the snake venom in the patient's body and actually lead to some symptoms that that may actually harm the patient. In addition to if you can use the neostigmine, always use it with tropine, just like she said, because the snake venom gives something that is similar to what myasthenia gravis will do, and then this can be a big challenge. But by and large, my worry is that some of these facilities may not be always available even in the best hospitals or the biggest hospitals in Nigeria, as we saw recently. So the important thing, I think, for all of us is to always be ready, always be prepared, always stock the things that we need in the anesthesia unit, in the emergency department. So I want to call on us, on our association, and every well-intentioned person to create adequate awareness, even among our colleagues, of the things that we can do and the things that any doctor can do and the things that should be readily available in our resuscitation areas, in the ER or wherever we have to resuscitate the patient, because like the patient may not even make it to the ICU. The patient may not even be able to get to see the anesthetist before death calls. So that's what I want to say. Thank you very much.
Thank you very much, Professor Mwaso, for the excellent contribution. So the questions are coming in now, but because of time, I think some of the questions are similar. Let me just summarize like this. Some of the questions are, what should a victim do at home? I think this person came late. You stated the first aid, but I don't know if you want to repeat.
Okay.
What should a victim do at home?
After raising the alarm, he's been bitten. The victim should try to stay calm. Easier said than done. The general public feels, the old school thought was tie a tourniquet to limit venous spread that was the reasoning behind tying a tourniquet, to prevent venous spread of the venom. Some people will tie it so tight that it turns to an arterial tourniquet and it causes more pain. But what I said earlier was try to keep calm, move the patient away safely, try to immobilize the leg or the limb by using a splint. They have this, I saw some pictures of this compressive bandage. It's like crepe bandage, where you compress the hand and or the leg, puts a splint left and right and compress. The idea of immobilizing the bitten limb is so that there's less muscular movement and muscular contraction that will help with the spread of the venom. And then ideally the person should be taken in an ambulance, but we don't have ambulance services. So ideally the person should be really kept as much as possible, less walking and running around, transported in a car, maybe lying down or something, taken to the ambulance, to the hospital for care. What to do at home? Then you have a snake, you bit somebody in the home,
I
you have
think
to.
the other one is, at what point do patients move to ICU?
Okay, the patient is observed in the ER. And once you start seeing signs of swelling increasing, patient having difficulty in speaking, see signs of neurotoxic or hemotoxic, patient should be moved at once to the ICU. Ideally, if the person comes with snake bites, the intensivist or the anesthetist should be notified, because you might be needed at any time in case there's respiratory paralysis or sudden collapse. But from what we've seen in the preparation for this presentation, if you have ICU facilities, you move to the ICU and observe the first 24 hours in the ICU. If you don't have ICU facilities, if the patient is taken to the ward, patient should be placed closest to the nursing bay, so they do the hourly observation to see if the patient is deteriorating. Maybe after 24 hours, there's no deterioration, the patient goes out. But if you notice these new signs, you can swing into action.
Yes. I don't know if this will also answer the question by Dr. Odukoye, who asks, how soon does the emergency department involve the anesthetist in a case of snake bite? I think that answers.
Yeah, I think early. They shouldn't wait. They shouldn't wait. I see from Dr. Rukewe.
They are requesting if you can please share your slide, make it available.
Yes, by all means.
All right.
By all
And
means.
I think there is a question for Professor Mwaso. I don't know if she's still around, regarding the safety of regional anesthesia in hemotoxic ventilation.
If the patient, if the patient is also already showing signs of coagulopathy, it might not be easy or wise to go ahead with a nerve block, especially if it is to a region where it will be difficult to compress in case a hematoma forms. That's my thinking. But if it is a nerve that's closer to the surface of the body, to the skin, it might be easier to make a block and apply pressure. Somebody says, when should we remove the tourniquet? One of the books there I read said, if a tourniquet is applied, you should have IV access and preferably give your anti-snake venom before you start to remove the tourniquet. The danger of removing the tourniquet late is that you will have lactic acid, potassium, possibly blood clots, and possibly rush of venom going into the body when you loosen it. So you should be prepared for cardiovascular collapse before you loosen that tourniquet. If the tourniquet has been tied for hours and hours, going to the hospital. Sometimes it's been tied for days and days and there's gangrene. And then you now need to do surgical intervention because, as I said, gangrene.
All right, thank you very much. There is also another one, but this looks more of a general question. And what can be done if you don't have the antivenom in the emergency room?
You will do syndromic management. If you really don't have antivenom, you just treat symptomatically and hope for the best. But the truth of the matter is, we really do need to have snake antivenom because the venom these are proteolytic enzymes. They're attacking the whole body. They're moving in different directions. Sometimes one snake has an overlap of neurotoxic and hemotoxic. So it might be bleeding and I'm giving so many units of blood and the venom is just going ahead and destroying the blood I'm transfusing. So it's not a nice situation to be in. And that's why you see me talking about collaboration.
Yes.
If we know we have antivenom in a place, you can call, they send it to you and you give, But as I understand, they're expensive.
Yes, those sharing the email, it will be difficult to send it to individual emails. I think maybe if the slide, the NSA will make it available on the WhatsApp group, it will be easier.
Okay.
So I cannot see any new question, only emails. So in the absence of that, we hand over back to the NSA Secretary General, Dr. Odukoye.
Sorry, Dr. Bala, sorry, Dr. Elumelu. I wanted to just clear the air. When I talked about possibility of using regional block, you have, as I mentioned when I said that it is tricky. It has a role that you can do it, but you have to exclude the bleeding type, the one that is a snake that has affected the clotting profile and the patient is bleeding excessively. So, and I said that when I made the comment, maybe the person didn't
hear
me. So it is not for every case. If you have a case that already there is problem with the clotology, when the problem there's clotting derangement of clotting profile, that is a contraindication to regional block, so you cannot do it. And then somebody was asking about where using the band to prevent the spread. Actually, in the old school, what we were taught was that you could use that, but it should be just as Dr. Elumelu said. It should be a venous tourniquet, not an arterial, that will prevent blood flow to the area. So the old teaching is that whatever the person is tying, a finger should be able to pass underneath it, and it should be above the point of the bite to avoid prevent flow of the venom into the general circulation. And if it's to be removed, it should be done after giving of the anti-snake venom, and it can be done in a stepwise or in a slow way, not at once, because sometimes it may be that actually the tie because it's already been in place. Well, I said don't put it, but now the person has put it, and it is possibly limiting the flow of the venom into the circulation, and then you remove it at once. So what has been prevented from going around for 1 hour or 2 hours just goes boop into the circulation. So that is also the problem of removing the tourniquet just as soon as possible, or without doing it in a stepwise manner. So some people advocate that it is moved away from the part of the snake bite slowly. Like the way we do Beer's block, that you have 2 tourniquets. You apply another up, then remove the one below, and until you can completely remove the tourniquet, and it must be after the anti-snake venom has been given and adequate IV infusion and all the investigations have been done. So that's just what I can say for that. But I think it's...
Yeah, thank you very much, Prof. And it's very good to have you here, your excellent contributions. And another reason why this tourniquet is discouraged, you know, when you tie the tourniquet, you are concentrating the venom in one place, and the possibility of losing the limb is high because of the neurotoxicity, the necrosis, all this. So that's why it's also discouraged. I think we'll recognize the last person to speak. Dr. Jonathan, you can unmute.
Yeah, good evening, everybody. My name is Dr. Jonathan. I'm a consultant anaesthetist from Enugu. Hello, can you hear me? Can you hear me?
Yes, I can hear you. We can hear you.
Dr. Jonathan is a consultant anaesthetist from Enugu State University Teaching Hospital. Well, thank you for the beautiful lecture. I just want to veer away from what may appear to be the norm, the orthodox treatment of snake bites. I don't know if you looked at some of the claims that local people make, by the use of herbs to manage some of these snake bites. Growing up in the village, I knew the one I obviously witnessed was scorpion bites. When scorpion bites somebody in the village, when we are in the village, there are herbs. They will just rush, get the herb, apply it to where they will rub it together and apply it there. And the person will get him or herself and go away and go for his normal business. They also claimed that they had similar herbs that could cure snakes, although practically I didn't witness one. But such claims are coming from the villages. And considering the fact that most villagers will not have this opportunity of even listening to this lecture to know what to do as a first aid, and they will not be able to access hospitals, is there a look, a searchlight into such claims, to see if we need to encourage them to continue with what they are doing or to discourage them?
That's an interesting angle. Thank you, Doctor. Even when I was preparing this, my own husband told me that in the village, on Icholona in Delta State, they have a man who specializes on treatment of snake bites. He has some herbs. And he said it, and I said, that's nice. If it works, it's nice. But for us as clinicians, I bet most of us don't know the name of the herbs or the type of herbs or how to recognize. I'm not saying these things don't work. I've heard a lot. I believe that some of them would work if it's, experienced people. As my husband said, this man is very old, very experienced. Any snake bite, they go to him, he treats, and the person gets better. Beautiful. My husband doesn't know the name of the herb or the plant. I don't know. And most of us as anesthetists are really in the urban areas. This is why I said there's a problem of accessibility to health care. Those who have the herbs are not going to come for us to see. Now, how do we do a study? Is it ethical or practical to have a study comparing the local herbs to anti-snake venom? I don't think anybody will really be able to do that type of study, comparative study, anti-snake venom versus local herbs. But it is worth going in there, speaking to them, trying to see the type of herb, and then we can do some analysis, work with the people in the labs and see what is the component of this anti-snake. It's worth researching. I will not disprove or, belittle what goes on in the villages. But we don't have standardization. Most of us as anesthetists don't even know the herbs. So we just stick with what we know and what we're taught.
Thank you very much, Dr. Elumelu. I think we have spent more
time.
And because
Okay.
this is a very interesting topic and it's timely, the controversies that recently occur in Nigeria
Yes.
because of
Yes. Oh, it's okay. So thank you very much. Once again, my
baby that
laptop
died,
has a
mention
problem.
another one because there was no anti-rabies, something like that. So I think we can continue the discussion on the NSA platform. So I don't know, Dr. Odukoye, are you there?
Thank you very much. I am here.
All right.
I want to especially thank the speaker, Dr. Elumelu, for this very succinct and very educational presentation on snake bites and the role of the anaesthetist. Before now, I'm sure many of us have been confused on what to do in terms of snake bites, but today she has she has taught us, or she has educated us on the importance of early recognition, basic management, and that airway assessment is very critical. Also, coagulopathy must be a guide to anesthetic decisions, and involvement of the ICU should also not be delayed when it comes to neurotoxic envenomation. So I really want to thank you, Ma, for this very beautiful presentation. I also want to thank Dr. Balak for moderating and keeping to time, and also the way he coordinated this webinar. Thank you, sir. It's been very excellent, and you have made the webinar very interesting and educative. I equally want to thank our senior professors available, especially Professor Onwanso, who has taken time to listen and giving us her own points of view, which has been very educational to those of us that are very energetic and quick to put in regional blocks and central lines. So we'll do this with care now, based on your education, Ma. Following this, on behalf of the NSA Educational Committee, in the absence of my chairman, Professor Mrs. Kalu, who is unavoidably absent as a result of the exams going on in her university right now. I want to thank everybody for participating, and we want to hope that this session has strengthened preparedness in managing severe snake bites and the complications that comes with it. Once again, I want to say a very big thank you, and I want to wish us a wonderful evening. Thank you very much.
Thank you. Thank you,
Thank you very
everybody.
much, and good evening, everyone.
Thank
Good
you.
evening.
So much. Thank you, Prof. I
Thank you,
appreciate
Prof.
your input.
Dr. Lumelu, that was so excellent. Marvelous. Well done.
Thank
Thank
you,
you
Mark.
for
I
all the
appreciate. I'm so sorry, my
Remember to
camera on my
share the
laptop is
slides.
not working, but my camera on my second device is working. At least I can say hello to everybody.
we've already seen you now.
Thank you.
When
Okay.
we say what people should not do, and then we find that they have done it already, we should have a scientific and stepwise way of doing it to not make what they have done to become a real bigger problem. Like when we're talking about, okay, you don't want to lose the limb. It's only somebody that is alive that will be worried about a limb. You understand? So if the tourniquet is already there, rushing to untie it may be more of a problem than the person that tied it themselves already. So you can't prevent patients from doing what they've done out of fear and anger, or just not knowing what to do, confusion. And so when in our way, we should be very careful to undo what they've done rather than to make what they've done to actually become their nadir. That's just what I want to say. Thank you, Dr. Lumelu. Thank you, ma'am. I've also joined the others in asking for the slides. I'm sure if you share with NSC.
Yes, I will just look through any corrections or top up, then I will share.
And I'm happy that the meeting is being recorded, so we'll be able to.
Okay, ma'am. Thank you so much.
Thanks, everybody. Bye.
Okay, bye-bye. Thank you so much. I hope we have mgtchrist@gmail. mgtchrist@gmail. I'm trying to